Have you ever stared at the ceiling at 3 in the morning, your body exhausted, but your mind wide awake? You're not alone. In fact, sleeplessness or medically insomnia may be one of the most common complaints we quietly carry and often dismiss. But let me ask you something. What if this sleeplessness isn't just a side effect of aging, but a message from the body asking us to pay attention? You see, sleep is not simply the absence of wakefulness. It's an active, biological process. Our brain cycles through stages: light sleep, deep sleep, and REM sleep. Each has a purpose, whether it's healing the body, processing memory, or balancing mood. But as we age, these stages shift. We get less deep sleep and more of the light, fragile kind. We become like old radios, picking up every small signal. A creaking door, a distant horn, a turn in bed, and we're awake. And our circadian rhythm, that internal clock we once took for granted, begins to wobble. Melatonin, the hormone that helps us fall asleep, declines. Sleep becomes lighter and more fragmented. We feel drowsy earlier in the evening and find ourselves staring at dawn far too soon. Now here's the truth we must hold on to, my friends. These changes are common, but they are not normal. Aging may change the architecture of sleep, but it does not have to erode its quality. Insomnia is not a sentence, it's a symptom. One that can point to deeper issues: pain, mood changes, grief, even poor habits we've picked up along the way. Let's take a moment to reflect, not just on the fact that we struggle with sleep, but on how we struggle with it. Because not all insomnia is the same, and the way it presents in the elderly is often different from younger individuals. Some lie awake for hours, waiting for sleep that never comes. That's what we call initial insomnia, difficulty falling asleep, often fueled by anxiety, racing thoughts, or even the body simply being unable to switch off after years of stress. Others may fall asleep easily, only to wake up at midnight or 2 a.m., eyes wide open, and then toss and turn for hours. This is middle insomnia, perhaps the most frustrating of all. It fragments our rest and leaves us tired in the morning, even if we think we slept long enough. Then there are those who wake far too early, often before sunrise, and simply can't return to sleep. This is terminal insomnia, and in many cases, especially in the elderly age group, it can be linked to underlying depression. I've seen it. There's another curious kind, one we don't talk about enough, called paradoxical insomnia. That's when someone feels they didn't sleep at all, but objective monitoring shows that they actually did. It's common in anxious individuals and sometimes in those whose perception of time has shifted with age. Now let's remember, most don't just have one type. They blend. One night you may struggle to fall asleep. The next you wake up 3 times. Over time, the pattern itself becomes distressing, and when that distress sets in, the insomnia worsens. In younger adults, insomnia is often standalone, but in older people, it's frequently comorbid. That is, it comes with something else, like chronic pain, prostate issues, diabetes-related nocturia, chronic usage of certain medications, even the loneliness that creeps in during long evenings. The real challenge, my friends, is recognizing that sleeplessness may be trying to tell us something about our body, our mood, our environment, or even our relationships. So when we think about insomnia, let's stop asking, "How many hours did I sleep?" and instead ask, "How do I feel in the morning? Is my sleep fragmented? Am I dreading the night? What has changed in my health or habits recently?" Only then can we begin to address it, not with guesswork, but with clarity. Causes and contributors of insomnia in the elderly. By now, we've understood the forms insomnia can take, but if we want to manage, we have to do it as a one-on-one approach. First, let's try and answer these questions. What causes it? What feeds it? In younger people, insomnia often comes from stress or a disrupted routine. In the elderly, it's rarely that simple. The reasons are layered. Often, it's not one single cause. but a combination, gently pulling at our sleep, night after night. Let's begin with the most obvious, medical conditions. Many of us live with chronic pain, be it from arthritis, spinal degeneration, or neuropathy. Pain may be tolerable during the day when we're distracted, but at night, in silence and stillness, it becomes magnified. There's nocturia, waking multiple times to urinate, often due to prostate enlargement in men, or overactive bladder in women, or simply the effects of diabetes. Every trip to the bathroom chips away at deep sleep. Then there's breathlessness, from COPD or heart failure, or acid reflux creeping up just as we lie down. Even Parkinson's disease and Alzheimer's can disrupt sleep through changes in brain chemistry and movement. Next, let's talk about psychological factors, the ones we don't always talk about openly. Anxiety and worry about health, finances, family don't retire with us. In fact, for many, they grow louder with age. Depression in the elderly often looks different. It's quiet, it's persistent, and it shows up in the form of waking too early or feeling unrested no matter how long we lie in bed. We must learn to recognize these signs in ourselves and in those we care for. Loneliness, grief, even the loss of purpose after retirement, these may not sound medical, but their effects on sleep are very real. Then there's the role of medications. We've accumulated quite a collection over the years, haven't we? Beta blockers, bronchodilators, steroids, antidepressants, diuretics. Some interfere with sleep directly, others by their side effects, like needing to use the bathroom or feeling jittery at night. Even substances we once thought harmless, like caffeine in our evening tea or alcohol as a nightcap, can sabotage sleep. Alcohol may help us doze off, but it fragments the second half of sleep and reduces REM. And then, there's something we often overlook: poor sleep hygiene. It sounds simple, but it's powerful. Irregular bedtimes, long afternoon naps, watching television or scrolling on our phones late into the evening, too little sunlight exposure in the day. All these cues confuse the body's natural rhythm. The brain, much like a child, thrives on structure. And finally, though rarely acknowledged, is the spiritual unrest that comes with aging. Questions about mortality, regrets, unfinished business. These too can find their way into the silence of the night, stealing our rest without warning. So when we speak of insomnia, let us not reduce it to a single symptom. Let us instead look beneath the surface, at the full picture: the body, the mind, the medications, the environment, even the heart. Because in understanding the causes, we begin to see where healing is possible, not just through tablets, but through awareness, kindness, and care. Assessment and diagnosis of insomnia in the elderly. We've talked about the types of insomnia and the many causes that contribute to it in the elderly. But now comes the most important task: assessment. Many adults don't mention about insomnia at all because they believe poor sleep is just a part of aging. It isn't. And we must ask ourselves simple questions like, what time do I go to bed and wake up? Do I fall asleep easily? How many times do I wake during the night? Do I feel refreshed in the morning? These questions can open doors. Then we go deeper. Am I feeling anxious or low? Have I lost interest in things you used to enjoy? Do I feel lonely, especially in the evenings? These are not just emotional questions. They are diagnostic tools. Ask about physical triggers. Do I wake to urinate? Do I have pain that worsens at night? Do I snore? Has anyone observed pauses in my breathing? These clues may point toward nocturia, chronic pain syndromes, or sleep apnea. And don't forget the medications. Review every prescription, every over-the-counter pill, every herbal tonic. You'd be surprised how many harmless medications interfere with sleep. You could maintain a sleep diary, something as simple as noting bedtime, wake time, number of awakenings, and naps for 1 or 2 weeks. Patterns emerge when we look closely. And for more complex cases, especially where obstructive sleep apnea or restless leg syndrome is suspected, a polysomnography, a sleep study, can provide clarity. Not with guesswork, but with clarity. Now comes the part we've all been waiting for. What can I do to sleep better? Well, sleep medication is not the first answer. In fact, for many of us, it shouldn't be the answer at all. If you have identified any underlying medical problem, finding solutions to the relevant conditions after appropriate evaluation by a consultant is a must before we proceed further. Let's try answer this question. How to sleep better? The path to better sleep begins not in the pharmacy, but in how we live our days and how we prepare for our nights. The first line of defense, and often the most effective, is sleep hygiene. It sounds simple, maybe even too simple, but it's powerful. Sleep hygiene means training the body and brain to expect rest at a regular time. It means going to bed and waking up at the same hour, even on weekends. It means keeping the bedroom dark, quiet, and cool. And yes, it means putting away phones, televisions, and bright screens at least an hour before bedtime. If you nap during the day, keep it short. 20 minutes ideally before 3 p.m. Long naps in the afternoon confuse the brain, and then, come night, it's not ready for rest. Then comes the role of natural light. This may surprise you, but one of the most effective treatments for insomnia is daylight. Our brains need exposure to natural light in the morning to regulate melatonin and reset the sleep-wake cycle. A morning walk, even for 10 minutes, can shift the rhythm of your entire day. And what about the racing thoughts, the overthinking? That's where relaxation techniques come in. Gentle breathing exercises before bed, a few minutes of pranayama, or simply lying still and focusing on the breath. For some, yoga nidra, a guided deep relaxation technique, works wonders. Others may find comfort in soft instrumental music or devotional chants playing gently in the background. Now, for those who need structured support, cognitive behavioral therapy for insomnia, or CBTI, is the gold standard. It's a short-term, non-drug treatment that helps retrain the brain to sleep more efficiently. It works by identifying unhelpful thoughts, limiting time in bed, and creating new associations between the bed and sleep. And the good news is, CBTI can be done in person, online, or even through apps now. No side effects, long-lasting results. And then, of course, we have medications, used carefully and only when truly needed. For example, a low-dose melatonin supplement. I'm talking 0.3 to 1 milligram, not the higher commercial doses, is often enough to help realign sleep timing. You always should take your physician advice for medications as a last resort after patiently trying all the above measures. And finally, don't forget the value of ritual. A warm cup of caffeine-free herbal tea, a short prayer, a bedtime routine that signals safety, stillness, and surrender. In our generation, we sometimes undervalue these quiet traditions, but they speak deeply to the nervous system. They matter. So let's remember, managing insomnia is not about knocking ourselves out. It's about creating the conditions where sleep can come naturally without struggle, like it used to when we were children. And even now, in these later years, that kind of rest is still possible. We don't need to chase sleep. We need to invite it, gently, consistently, and with care. And in doing so, we give our bodies and our minds the rest they truly deserve.